Welcome back. Our next speaker is Dr. Martina McGrath. Dr. McGrath is the medical director of the Live Kidney Donation at the Brigham. She's an experienced clinician and an educator, and she's the director of the Master of Medical Sciences and Clinical Investigation at Harvard Medical School, and she'll be talking to us today about donor evaluation.
Great. Thank you very much, everyone. This is me. These are my disclosures, none of which are relevant to this particular talk. So over the next 30 minutes, I'd like to run through some of the physiological changes that we see after kidney donation. I'm going to show you some of the data around the risk of end-stage kidney disease, particularly after donation. I'll talk a little bit about risk prediction models that are available. And throughout the talk, I'll talk about young donors, older donors, and then at the end, some focus on APOL1 risk alleles. So I think everyone here is quite aware of the scope of the problem. So at any given time, there are over 100,000 patients on the kidney recipient wait list, of which a number are removed every month, many because they're too sick to undergo transplant, but around 300 patients per month die waiting for a kidney transplant. And living kidney donation is one of the areas of potential expansion where we could really improve the number of kidneys that we have for transplant. What are the benefits of live kidney donation? So it facilitates faster access to transplant and in some cases the ability to avoid dialysis entirely, which is associated with much superior long-term outcomes. There is generally longer and better function of a live donor transplant kidney compared with a deceased donor kidney. With our newer matching and exchange programs, there's potential for a better matched kidney, which can make the immunological and immunosuppressive management easier in the long term. There are lower rates of delayed graft function, so a shorter first admission at the time of transplant and often less morbidity. And there's some flexibility in terms of finding a donor with exchange programs and the potential for advanced kidney donation. Just to emphasize for you the difference in outcomes between live and deceased donor kidneys, the median survival for a live donor kidney in the current era is around about 19 years, compared with 12 years for a deceased donor kidney. And where there is the opportunity for preemptive transplantation, this is where we see the best outcomes both for the kidney and for the long-term recipient survival. So one of the most important things is how do we assess kidney function in kidney donors. And so this is different really to everything else that we do in medicine, where we are screening to confirm health rather than to exclude disease. So it's a really different mindset in caring for these patients. We think a lot about their future risk of end-stage kidney disease, and this takes into account their demographic risk factors, as well as risks that are associated to specific health characteristics. One of the big unknowns, particularly for younger donors, is around the donation attributable risk. And so there is some uncertainty. We have a lot more data over the last 10 years that can guide us in these discussions and help us predict risk in these patients. The KDIGO guidelines have put forward this, this kind of ethos of each program should establish numeric thresholds for short-term and long-term post-donation risks within which they are comfortable accepting candidates. And really, there has to be this individualized quantitative estimates allowing kind of discussion with donors and shared decision-making within those safety parameters. So kidney function should be assessed during GFR. eGFR is used for screening. The ideal measurement of kidney function in a donor is by measured creatinine clearance by iothalamate, inulin, or radioisotope clearance. This is not routinely available at all centers. And so many centers use 24-hour urine collections for creatinine clearance, as well as repeated measures of eGFR, and combine estimates using both creatinine and cystatin C. There are a number of thresholds that are determined. So if you go through the KDIGO guidelines, patients who are below 60 at the initial clearance are excluded. Those who are between 60 and 90 may undergo confirmatory tests to evaluate the consistency of results. And then depending on where they fall within the given GFR categories, an estimation is made of their long-term risk and to establish whether they fall within an acceptable risk threshold or not for an individual transplant program. So an acceptable creatinine clearance is greater than 90 mils per minute for pretty much all candidates. However, for those who with lower GFR, there can be some individualized decision making. KDIGO talks about going down to 60 mils per minute, which is lower than I think many programs do in clinical practice. The advice is to counsel patients about this increased risk of end-stage kidney disease, but the absolute risk, at least out to 15 years, remains quite low. The other piece to emphasize is that donors with hypertension that is well controlled and who do not have end organ damage, by that I mean absence of albuminuria, EKG or echo abnormalities, they may be suitable to donate. So one of the things that really determines compensation and recovery post-kidney donation is nephron endowment. And when we're in medical school, we learn that there's 1 million nephrons in each kidney, but actually that's not technically accurate. Autopsy studies have shown that there can be anywhere from 200,000 up to 1.5 million nephrons in each kidney. And this goes back to seminal work that was done by Dr. Brenner. As you can see in these graphs here, there is a decrease in the number of nephrons per kidney that is associated with aging. And this is a major determinant of what the compensation is after people donate a kidney. The other important piece here is that there is this susceptibility to kidney disease associated with low birth weight, and there is this concept of nephron endowment. Those who were born preterm or at low birth weight tend to have lower numbers of nephrons and higher susceptibility to albuminuria and end-stage kidney disease in lifetime. This will be a consideration when we're thinking about them as potential donors. The other piece to think about is in those who have lower numbers of nephrons, there is a higher single nephron GFR in terms of contribution to overall GFR. This is a group from Australia who quantified this across age along in this substantial cohort of kidney donors. What I find particularly, I think, thought-provoking here is if you look at the age group of the age 60 to 64, these individuals tend to have about 750,000 donors, 750,000 nephrons per kidney with a total GFR of around 100 mils per minute. Those that are in the 70 to 75 age group, GFR is a little lower at 96 mils per minute on average, but they have this substantially lower number of nephrons and this really higher single nephron GFR. When one then takes away a number of these nephrons, there's going to be less capacity to increase the single nephron GFR, and you may see a bigger drop in GFR overall. So again, thinking about birth weight, body size, and family history of end-stage kidney disease is also associated with lower nephron endowment. There are wide variations across age and single nephron GFR, and this is an important determinant of total GFR post-donation. So what happens when you donate a kidney? So the nephron mass obviously decreases by 50%, but GFR in the remaining kidney increases by 20 to 40% in the following weeks. So this is predominantly a hemodynamic change and has been termed adaptive hyperfiltration. So there have been some nice physiologic studies to try to look at what is actually going on in the kidney when someone donates. And what you see is this increase in single kidney GFR over time. So this is early within the first years, late as more than 6 years post-donation in this study. And that is associated with an increase in single kidney renal plasma flow. And this change in serum creatinine, where the creatinine initially goes up in the first week or two after donation and then comes down as this adaptation occurs, so that overall you have a well-maintained GFR. So this appears to be due to an increased glomerular filtration, but without evidence of glomerular hypertension and without the development of albuminuria. So this appears to be an adaptive rather than a pathologic change. So in terms of the risk of end-stage kidney disease after donation, so this JAMA paper from 2014 is really the one that initially highlighted most clearly this increase in risk. So this was a nice study of 96,000 kidney donors who were matched with 20,000 controls from NHANES 3. The difference between this study and many of the preceding studies with that were the selection of the controls. These were patients who were really suitably low risk to be compared with healthy kidney donors. And so as you can see on this median follow-up of up to 15 years, there is this much higher risk of end-stage kidney disease in donors as compared to non-donors. Okay. In this particular study as well, they looked at subgroups across ages and across race. And as you can see, the highest number of ESKD events occurred in those who were over the age of 60. But strikingly, there were also a number that occurred in this younger age group of 18 to 39 years. When this was examined across race, Black men have the highest risk of end-stage kidney disease after donation, followed by Black women. Then white men are lower risk and white women are the lowest risk in this particular analysis. So if we look at the absolute numbers, so the cumulative incidence of end-stage kidney disease at 15 years was 30 per 10,000 in donors compared with 3.9 per 10,000 in non-donors, giving you a lifetime risk of 90 per 10,000 donors, 14 per 10,000 non-donors. So this is a 6 to 8-fold relative increase in end-stage kidney disease. I think the important point to emphasize is that the numbers in these studies are small, so the absolute risk remains quite low and for the most part is under the 5% lifetime risk threshold. So it is well below a general unselected population risk, but unquestionably, there are patients who donate kidneys and subsequently do develop end-stage kidney disease. What about other risks? So this large meta-analysis tried to look at risks of other health outcomes. So in this forest plot, you can see for all-cause mortality, there is no change in risk in kidney donors, no change in risk of cancer. There's been no evidence to show a change in risk of cardiovascular disease, which I think we all find quite reassuring in kidney donors. No change in risk of diabetes. The data around hypertension, I think, is a little bit unclear. You can see that some of these studies are far to the right, some are to the left. Overall, in the pooled analysis, there does not appear to be an increase in risk in hypertension, but this is something that I always discuss with my kidney donors because I think it's something that can be easily taken care of and followed to reduce the risk of progressive CKD later. What has been shown to have increased risk, so I showed you the data on end-stage kidney disease, but pregnancy following kidney donation also is associated with increased risk. So there's an elevated risk of gestational hypertension. There are observational registry studies that have shown that the risk of preeclampsia post-donation is essentially doubled. And so there is also an increased risk of low birth weight and preterm birth in women who have pregnancies after kidney donation. So essentially, what our advice is always that women should wait at least 1 year after donation before undertaking a pregnancy, and then they should be followed at a high-risk fetal maternal medicine clinic for that pregnancy. One of the big concerns is that is really thinking about younger donors in terms of kidney disease and where does kidney disease occur in a lifetime. And so if we Bob Steiner has written very eloquently about this in a number of papers and really emphasizes this point that only 10% of end-stage kidney disease occurs before the age of 40 and 50% occurs after the age of 65. So there's really this non-linear onset of end-stage kidney disease with this very significant time lag between the development of CKD and the later progression of end-stage kidney disease, which makes risk prediction very difficult in a young person. For any donor, donation is associated with losing about 25 to 40 mils per minute loss of GFR, but the significance of that really depends on what type of kidney disease they may develop afterwards and what is the rate of progression of that kidney disease. And so to emphasize that, I quite like this schematic. In the black here, we look at a regular individual who does not donate a kidney. We all get some age-related GFR loss as we move into our 70s and 80s. If you have a second hit with maybe a low nephron endowment in utero, or you develop diabetes or some other age in middle life, the slope of your GFR loss over your lifetime changes. And so you see this greater loss in GFR. However, if you donate a kidney, you move down to this gray line. So you've given away 25 to 40 mils of GFR. You then have the same age-related decline, but where the problem arises is if people develop another issue during that lifetime, and that may be where they will reach this threshold around where they may end up on dialysis, where they would never have done so with the same hit, but with that earlier loss in GFR, and they reach that threshold at a younger age. So risk prediction is very important. So the GRAMS calculator was developed in this paper in the New England Journal of Medicine in 2016. This used data from 5 million healthy participants who were considered healthy enough that they might have been potentially eligible to donate. And then there was median follow-up for 16 years. The calculator was used to develop their projected risk of end-stage kidney disease based on demographic characteristics, as well as health-related characteristics. And then this projection was compared with the observed incidence of end-stage kidney disease in 53,000 donors at about 15 years after donation. And so the calculator is available. I'll show it to you later. But again, in this paper, they illustrated some scenarios in terms of how this might influence our thinking in evaluating donors. And I think a couple of these are quite informative. So first of all, in scenario 4 here, if I look at a 20-year-old Black donor with a GFR of 115 mils per minute and an albumin to creatinine ratio of 30, systolic blood pressure of 140, a current smoker, they are not at elevated 15-year risk of end-stage kidney disease. So their hazard ratio is 0.7, with the hazard ratio that crosses 1. However, if you look at the lifetime risk, according to this modeling, they have a hazard ratio of 13 for end-stage kidney disease. So substantially increased risk in the long term. I think what is thought-provoking about this analysis as well is if you look at a 60-year-old white donor with a GFR of 60 mils per minute, same albumin to creatinine ratio, same blood pressure, also a smoker, this individual is at elevated 15-year risk of end-stage kidney disease, 2.2-fold. However, their absolute lifetime risk of end-stage kidney disease at a hazard of 4 is elevated for sure, but is still lower than that 20-year-old Black donor who has a much higher GFR at the time of donation. And this gets into this question of time and race that are very challenging to think about as we assess donors. This is the website, transplantmodels.com, where you can access all of these calculators. And essentially what you see is there's the calculator comes up, it asks you to enter the parameters like blood pressure, presence of diabetes, smoking, and it will give you a projected lifetime risk of end-stage kidney disease. How I use it then is I multiply that number by about 5 to 8 based on the original JAMA paper that shows donations associated with the 5 to 8-fold increased risk. And then you have some numbers that you can broadly use to talk to donors about their lifetime risk. However, again, this comes back to thinking about how do we use this in young donors? So again, Bob Steiner has said, how can end-stage kidney disease be predicted by an algorithm that doesn't really predict any specific disease? And I think that's one of the big problems that arises here. We have a young, if you have a younger population with a rare event versus an older population, accurately estimating that risk is challenging. And again, coming back to that point that end-stage kidney disease is not a linear risk throughout lifetime. It is low rates at a young age, certainly under 40, with this exponential increase as people get over 65. And so I would caution about being falsely reassured by the calculators when they are used in young donors due to the short follow-up that was employed in actually developing the calculators. What about older donors? So I've shown you how the calculator may be helpful in using older donors, and older donors are an important source of living kidneys We do see this loss of nephrons as we age. I talked about the increase in globally sclerosed glomeruli per kidney with aging, but the data on long-term follow-up of older kidney donors, and by this I mean over the age of 60, is quite reassuring. So this is a cohort of 500 live donors from the Netherlands, where if you look at GFR in the dark line, these are the donors who are under the age of 60, versus the gray line, these are donors who are over 60. And so what you see is that the younger donors are starting from a higher GFR. There is a similar absolute loss of GFR across the two groups. So the older donors end up at a slightly lower GFR, but the slope of GFR loss between the two groups is exactly the same. And so while there's a higher incidence of developing a GFR less than 60 mils per minute, so it was seen in 80% of those over 60 in this cohort versus only 30% in the younger cohort, there was no GFR of less than 30 mils per minute, and the long-term outcomes look quite good in this particular analysis. Others have looked at older kidney donors with hypertension. Are those at higher risk of end-stage kidney disease? So in this particular analysis of 2,200 donors over the age of 50, their 15 risk of end-stage kidney disease was slightly increased in those with hypertension, but there was no increase in mortality and no increase in risk of cardiovascular disease across this study and several similar analyses. So based on these data, there's a move towards incorporating age-appropriate GFR thresholds for donation. So KDIGO has used this greater than 90 for all comers, shared decision-making between 85 and 90 in consideration of other risk factors and lifetime risk of end-stage kidney disease. Again, I would emphasize that for all of these GFR thresholds, all of these use a cutoff of less than 30 milligrams per gram of urine albumin to creatinine ratio. So there is no flexibility in terms of albuminuria, even if there is some flexibility in terms of GFR for older donors. The British Transplantation Society guideline recommends that the baseline GFR should be more than 2 standard deviations above the mean for age, so age-appropriate GFR. And for those under 30, they should have a GFR more than 90 mils per minute. The Canadians have more detailed guidelines, so they say more than 90 mils per minute for those under 30, more than 85 for those under 40, and then decreasing GFR thresholds for older donors. So in the last few minutes, I'd like to talk a little bit about the role of APOL1 risk alleles in terms of what we see for this increased risk of end-stage kidney disease that I showed you in the original 2014 JAMA paper, where we saw African-American donors have higher risk than white donors. There's been a lot of discussion of how much of this is socioeconomic, how much of this is barriers to healthcare and other social determinants of health, but how much can be determined by the effect of APOL1 risk alleles. This is a very important conversation because African-American recipients are disadvantaged in terms of their access to transplantation. And I think a kind of nuanced discussion here is important to avoid introducing unnecessary barriers to live kidney donation for this same population. Okay, so to talk a little bit about APOL1, so 13% of individuals of near African ancestry carry 2 APOL1 risk alleles. However, if you have a family member who has end-stage kidney disease, that rate goes up to about 20%. So there is clustering, obviously, within those who have kidney disease. So this is an analysis from JAMA from June of this year, retrospective carried out by the Apollo Network, where they looked at African-American donors with and without APOL1 risk alleles. So these study visits were on average about 18 and a half years after donation. The primary outcome of this analysis was an eGFR less than 45 mils per minute. And as you can see, this occurred more frequently in those Black donors with APOL1 risk alleles compared with those without. On the adjusted analysis after adjustment for baseline GFR, this did not reach statistical significance, however. If we look at the other outcomes, end-stage kidney disease was rare but was commoner in those with APOL1 risk alleles. There was certainly an increased risk of a GFR less than 60 mils per minute in those with the risk alleles, even after adjustment for baseline GFR. So this is a 34% increase in risk. There was a trend towards an increase in urine albumin to creatinine ratio greater than 30, but certainly a marked increase in the risk of urine ACR greater than 300 milligrams per gram, which would be considered quite abnormal. So this was seen in 6% of the APOL1 donors compared with 1.6% without. Hypertension was also slightly increased in these donors. So I think, several of these do not reach the threshold for statistical significance. Some of the events are small, but I think what does give cause for pause is that all of the effect measurements are all in the same direction. So they do appear to be some higher risk of negative outcomes in these donors. So as I mentioned, counseling around APOL1 risk alleles and living kidney donation, this is really about balancing donor risk and ensuring equitable access to transplantation because, while the trends were present on that analysis that I showed you, the absolute numbers of things like end-stage kidney disease are small. And so I think taking APOL1 genetic testing into account, it needs to be put together more broadly with the other risk factors that we look for donors. So, are they young age? Do they have pre-diabetes? Do they have hypertension? Does this put them into a higher risk category rather than taking the presence of these risk alleles as an absolute contraindication to donation? I don't think that the data supports that at this point. There is the prospective Apollo study that is ongoing, looking at donors who are APOL1 positive, and that will be available in the next number of years. And really, all of this raises discussions around the appropriate use of genetic testing for these donors. And I think there are many opportunities for patient counseling and shared decision making as we look at individuals and their particular drive to donate, what the circumstances might be, and what their own individual risk is, as best we can think about. And so, in summary, as I've shown you early on post-kidney donation, the single nephron GFR increases with increased plasma flow. This is what we term adaptive hyperfiltration. And this compensatory effect can continue for 10 years after donation, but the degree of compensation really is determined by underlying renal reserve, how many nephrons you have in the remaining kidney. End-stage kidney disease following live kidney donation is fortunately a very rare event. There is variability across patient groups, and there are certainly some important characteristics that we can look at that can help us risk stratify patient. There do appear to be increased risk of hypertension following donation. There's increased risk of preeclampsia, and data I haven't shown you show slight increase in risk in gout and possible increase in LV mass. The risk factors for adverse outcomes that we talked about today specifically are those with low nephron endowment, lower GFR at the time of donation, that APOL1 risk alleles may appear to be a risk factor, as well as others, such things like family history and other metabolic concerns. Younger donors have elevated lifetime risk, mainly due to unpredictable events. However, in contrast, the prognosis for older donors is dependent on their GFR at the time of donation, and reassuringly, the slope of GFR loss is similar to younger donors. So many of these individuals can safely donate. Risk calculators do appear to have some predicted value, and there are selected donors with lower GFRs who may be quite safe to donate if they're otherwise carefully screened, but more data is always useful. So thank you very much for your attention. Apologize for the technical issues, and thank you for your time.
Thank you very much, Martina.